I would like to call upon the next speaker, Dr. Shakthesh from Chennai. He will be presenting from planning to recovery, safety essentials in single-stage multi-level surgery.
Good evening, everybody. If you are all feeling sleepy, I'll not blame you all for that. I think Shankar is to be blamed, and particularly the biryani that he served us. So, if you are feeling sleepy, it's all right. So, continuing about Shankar, I remember Shankar as my guru's postgraduate, Anthony sir's postgraduate. He called me one day and said, I have my favorite PG who wants to learn about OSA. Then he called me and then said, "Namba enga poninga Italy poninga nu sonnanga, where should I go, where should I start?" I said, see, gone are the days where you have to travel abroad to learn about OSA. And then I told Shankar, we have all the experts to learn OSA in our country, and then I suggested that he go to my very good friend Srinivas Kishore and learn about OSA. From that point on, he has come a very long way, evolved into a very mature sleep surgeon, and not just that, he has evolved into a person who is capable of organizing not one successful conference but two successful conferences in a row. Congratulations and best wishes. Happy to see you, Shankar, in this place. And he is not just into organizing conference. One of the difficult topic to present in an OSA is the management of simple snoring. He has taken the difficult task on himself, and I think he has done a great justice to that topic. Fantastic, congratulations to that also. So coming to my topic, how many of you like multitasking? Raise hands. Okay, I think only 2, 3, 4. I am not surprised about the female hand going up. And now, how many of you actually do multitasking in your daily life? A lot more hands are rising. So I too belong to the second category. If you have come to me a few years back, I would have said, I hate multitasking. I hate multitasking. If you ask me, now do I like multitasking? I still hate multitasking, but over the years I have got good at multitasking. So that is the thing. The similar analogy applies to this topic here. See, you know that OSA is a multifactorial condition. So one treatment will not going to help all of your patients. You have to address more than one things happening parallelly to give a successful outcome to the patient. So, but then it brings with it a set of challenges when you are planning for this multi-level airway surgery. So this has always been a topic of debate when you go for any OSA related workshop or conference, whether to do a single stage procedure or a multi-level airway surgeries. So we all love to deal with one thing at a time, but then practicality doesn't give us that luxury. So you have to deal with multi-level surgery. So how to go about it? That's going to be the idea of this topic. So why we are interested, why we are here, moderate to severe sleep apnea is prevalent among 32.5% of Indians. That means 1 out of 3 people in this hall have sleep apnea. That's what this study says. So we need a lot of people who are trained and aware about managing sleep apnea, because managing sleep apnea is tricky. You can do a wonderfully beautiful surgery, but if you do the surgery on the wrong patient, it's still going to be a failure. So we need a lot of trained people, and that's why a lot of courses are happening in our places. And about this multi-level airway collapse, 71% of OSA patients are known to have more than one level of collapse. Only 28% have single level airway collapse. So you are looking at a majority of people who are going to have multi-level. So it makes sense to do multi-level airway surgery, and the severity of the condition correlates with the number of level of obstruction that are happening. So multi-level airway surgery by definition refers to more than one level, that is nose, palate, retrolingual and hypopharyngeal conditions. If it involves more than one level, it is called as a multi-level airway surgery. So common surgeries that we will be talking about will be this nasal surgery, palatal surgery, tongue base and epiglottis, and sometimes craniofacial surgeries, which you have to combine with one another depending upon the patient. So what's the rationale? What is the, why not deal with it in separate sittings? One is, number one thing I would say is our country's healthcare infrastructure. So we don't have the luxury of telling the patient that there are 3 problems, you have to get operated 3 times, you will lose almost all of your patients. So our philosophy is that you go to a doctor, you give them one shot fix. So that's number one rationale in our country. Then of course, from a patient's perspective, they are more comfortable if they are offered a single stage solution for their problem. So they are not bothered about what are all the things which are contributing to their OSA. In their view, OSA is one problem. You offer me one solution for the problem. That is their perspective. So that's another rationale. And of course, in India, you cannot stop your discussion without discussing about the cost. So that's another important reason. But of course, another important thing pops up is that all the while thinking about all these rationale, we also have to balance it against the safety consideration involved. So that is the essence of this talk. So the most important thing to decide, see which patient to do multi-level airway surgery and when not to do multi-level airway surgery. The most important thing is the patient selection and pre-operative evaluation. So you have to do a thorough comprehensive airway assessment, particularly by doing a DICE polygraphy. I'll just, as we go on, I'll tell you why this DICE polygraphy is advantageous, not just to diagnose, also to risk stratify our patients. And of course, you also do comorbidity screening. So you cannot like apply the same logic to every other patient. So you have to see the patient as a whole, look at his age, look at his comorbidity, and then decide whether you're going to do a single level or multi-level. So and then you have to optimize. So you have to, if it is an obese patient, consider doing some obesity management before you take up for a multi-level thing. And of course, CPAP trial to bring down the inflammation before you take up, subject the patient to multi-level airway surgery. So I was talking about DICE polygraphy, why it is important. I will say it is important in 3 ways. Depending upon the level of obstruction and the type of obstruction. If you are seeing like a huge adenoids, huge tonsil and huge lingual tonsil hypertrophy, you can go ahead and boldly plan a multi-level airway surgery. Whereas if it is an unfavorable multi-level issues like a muscular tongue base and a very short palate, all those things if you consider, definitely you are pushing up the risk level. So definitely depending upon the type and the reason behind the collapse, you can take a choice by doing a simple DICE polygraphy. And by looking at the type of collapse, another important thing that we can learn by doing this DICE is the nature of collapse, how long the patient kind of takes to open up the airway, what is the level of desaturations that are happening, does he develop any aspiration while desaturating. All these things can tell you whether he is a low risk patient or a high risk patient. And then most important thing, if you ask me, is the anesthetic and perioperative safety. So from the most important person in the team of management of obstructive sleep apnea is the anesthetist. So you should have an anesthetist who agrees with you on that this patient can be subjected safely for multi-level single stage surgery. So you always have an experienced anesthetist with advanced airway surgery tool. You always do this procedure in a center which is well equipped to manage whatever outcomes that are expected to happen. Extubate only when fully awake and in semi-upright position. Always monitoring and post-operative care is very important. So make sure that your hospital has a good ICU setup to manage your patients. So this is another video of like why the anesthetic consideration is very important. This patient is from a we were talking about the risk stratification. This patient was having a very long collapse. Patient was not opening up. So these are not good candidates for a multi-level airway surgery. So this patient, I think the hope. So this patient, it is a DICE procedure. It was not an intrasurgical patient. So you can see the rapidly with very small amount of propofol, he started rapidly desaturating patient. These OSA patients are altered airway patients, so you cannot predict the way their airway will behave. So he completely desaturated. So these are all clues which tell us that they are not going to be good surgical candidates for a multi-level airway procedure. And of course, intraoperative surgical safety, I cannot emphasize enough. So hemostasis, use tools which kind of reduce the chance of bleeding and edema like your coagulation. So all these things in terms of reducing the risk and also reducing the operative time goes a long way in increasing the safety of the outcome. And all these new technologies allows us to do a very safe multi-level airway procedures. And post-operatively, you have to be aware about the airway edema risk. So you have to give them steroid prophylaxis, and by using techniques like coagulation and other things which kind of minimize the post-operative edema, we can ensure that this airway edema is not a huge problem. And of course, the pain is another important thing. So we have to be prepared to manage that pain associated with multi-level airway procedures. And of course, like I said before, a proper respiratory monitoring in an ICU setup is very important in the immediate recovery phase. And of course, you have to be vigilant about whether the complication happens or not. You should be ready with whatever possible complications that can arise and how to manage. We should be ready with a plan. And there have been a lot of debate, like I said before, about whether to go with this single stage or multi-stage. And now we have a consensus that the multi-level airway surgery is safe and makes sense, provided that we are able to satisfy certain requirements. So the current consensus, it is that if you are a person who routinely does sleep surgery and your entire staff are used to handling these patients, it is okay to do multi-level airway surgery. But you are somebody that you are doing once in a while sleep surgery and your team is not yet fully oriented towards managing this patient, it is better not to go with multi-level airway surgeries, at least in your initial period. Once you gain experience, you can switch over to multi-level airway surgery. And like I said, the anesthetist is the most important person, and you should have a good ICU backup. Don't do it in a center which does not have all these facilities. And finally, the patient selection once again is the most important thing. So take home messages, it is the preparation. The safety starts with the preparation of patient. Which patient you select and how you prepare them matters the most. And anesthesia, once again I keep on telling that because they are the most important people. Don't make compromises with your anesthetist. Have the person who is confident and familiar with this procedure, and post-operatively be vigilant about whatever complications that can happen and be prepared to handle them. And you have consensus now that multi-level airway surgery is okay. Gone are the days of debate. So multi-level airway surgery is okay, provided you satisfy all the requirements that we discussed. So thank you, and I shall be happy to answer any questions if you may have.
Excellent talk, Satish, as usual. So regarding the opioid analgesics, usually we will be keeping that buprenorphine in patch, no?
Yes.
For multi-level patients, we will be keeping that, or we will be doing some other?
We leave it to the anesthetist, sir. Generally, we eventually give them analgesia. When we start the buprenorphine patch, depends upon the call by the anesthetist. Most of the time, they want a few hours, they want the patient to be fully awake before thing. Another thing is that we want the patient to spend at least 6 hours after putting this opioid patches, so that we kind of see if they develop any unusual respiratory depression with these patches. So both are important. When we put and how long we keep them after applying the patch is also important.
Which are the patients you avoid doing multi-level surgery?
Bad anesthesia patients, when the level like I showed you one patient where he was a long collapse and other things, it is better to go with single stage with.
In that connection, can there be a guide as to which are the surgeries that can be combined safely?
Sir, all the surgeries, mostly all the soft palate surgeries, we do routinely. If you ask my routine to answer Ravichandran sir's question, in our center we do multi-level. If we choose surgery, if we decide that the patient is a surgical candidate, we do multi-level. But it depends upon where you operate. So if you are a person who is starting sleep surgery, definitely I would not advise doing that. So you better be like very, very judicious, go with single stage, and then as you get experience, we also started that way only. So I would also like to take this opportunity to invite you all to our conference, No Snore Con 2026. We are having it in Chennai. So the concept is mastering sleep apnea, right from fundamentals to surgical excellence. It all started with my guru Anthony sir's insistence, he has been asking me to host a conference for more than 15 varshama, sir. So I've been so lazy that not like Shankar. So I've been very lazy, but finally I woke up and decided that, and thanks to Srini also. So we decided, and we wanted the conference to cover every aspect of sleep apnea. So we start from the very basics and go all the way up to what is the latest thing. We also have a hands-on workshop on coblation, sheephead workshop is there, and we also have a workshop instructional course on how to interpret polysomnography and how to do DICE polygraphy. All these things are going to be definitely beneficial if you are interested in sleep surgery. So I would like you to register for this conference. You can visit www.nosnorecon.com and register if you are interested in sleep surgery. So with that, thank you again, Shankar, for this opportunity. Thank you again.
Thank you, doctor. Please be on the stage. Please be on the stage, doctor. Please. I request Dr. Shankara Subramaniam to award the momentum to Dr. Shakthesh.